The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
So in the tea break, Ronaldo said to me, "What are you doing here? This isn't your gig. You're not interested in quality and safety." I think we all are in our own way. Just disclosures to start with. I've been on the steering committee of some phase 3 sepsis trials, the Prowess shock trial that killed off Zygris, the access study that showed a toll-like receptor 4 antagonist didn't help in sepsis, and I've just accepted an invitation to be on the steering committee for Bristol Myers Squibb's phase 3 study of nivolumab, which you will be most familiar with as a drug that's used to treat melanoma and other types of cancers, which is going to be trialled in sepsis. I also currently chair the International Sepsis Forum Council. I'm a member of the GSA Executive Board, which are both charities, but they accept industry sponsorship. But all that money goes to either my employers or research funds. So I was asked, Daryl asked me to talk about treating sepsis, presumably in the context of the deteriorating patient. He asked me because he couldn't get the person he really wanted to do this to come, and he thought and when I accepted, I didn't know I was moving house last Friday, and I'm currently living out of 150 boxes. So I'm going to talk about treating sepsis from the sort of deteriorating patient perspective. But I'm going to start by showing you a video just to remind you what sepsis is. Hopefully we can have the sound. Do we have a technician? No. Well, if we don't have sound, this is a waste of time. In which case, anyway, that's a lady who is from Queensland who developed severe sepsis, had delayed treatment, out-of-hospital sepsis, delayed treatment, and ended up losing, as you can see, her arms and her legs. This is the very severe end of sepsis. And interestingly, although we're talking about the deteriorating patient, 70 to 80% of sepsis actually comes in through the emergency department. So what happens in the ward is a small component of it, but it's an important component. Now, Ronaldo alluded to the fact that there is no coordinated approach to sepsis. And this is true in most of the world. It's changed, and there's been some big steps forward in other countries. And as part of my role, I was very happy within the Global Sepsis Alliance. We promoted a resolution on sepsis to the World Health Organization. It was proposed by the German government, myself and some others, and there was support from the Australian Commission to get our government to support it. And in fact, the Australian government is a co-sponsor of this resolution that was adopted by the World Health Assembly. So this is a huge step forward. And here, gives us quite a big either a big stick or a lever, depending on how you look at it, as our government co-sponsored this, and I'm talking here about Australia. New Zealand, I don't think did, but it gives us quite a big lever to work on a national action plan for sepsis. So when we knew that we had to wait until we actually knew it was going to be accepted, that the WHA was going to adopt this resolution, and then I got in touch with Jeff Drazen at the New England, and he kindly agreed to publish a perspective article on this, which actually appears in last week's print edition, or the current print edition of the New England. And in that there's a table which I put together which summarizes all the things that the World Health Assembly urges member states, so governments, to do. And in that is this one, which is to train healthcare workers about the importance of sepsis as a time-critical medical emergency, as a key element for averting deterioration and ensuring patient safety. And you've heard from Daryl that this is probably a large cause of why people deteriorate. Now, should we need to teach people that this is a time-critical medical emergency. Now, I'm going to assume that you're all healthcare workers, most of you. I'd like you to put your hand up if you've prescribed antibiotics for someone with sepsis recently. Okay. Keep your hand up. There's a few hands gone down already. Keep your hand up if you actually checked when the antibiotics were given. Ronaldo's done it twice. Well, that's good, because most people prescribe the antibiotics, or if you're a specialist like Ronaldo, tell someone else to prescribe the antibiotics, and then that's the end of the game. And we don't do the same thing with other time-critical interventions. And Ronaldo has alluded to myocardial infarction. Stroke is, again, stroke's even more, time-focused in our hospital anyway. I mean, they've got a system for myocardial infarction now. You come through the door, you're put on a conveyor belt, you end up in the cath lab, and then you end up in the ICU or coronary care or whatever. We don't have that for sepsis. Now, if you think you've read the paper that Ronaldo was a co-author on, that mortality from sepsis in Australia is 18%, we've really sort of cracked this, it doesn't matter. But as he told you, the criteria by which you diagnose sepsis determines what your outcome is, or what outcome you appear to have. So I had two very, very hard-working Dutch medical students came to Sydney. They thought they were coming for a holiday. They came on a research fellowship, and they worked extraordinarily hard. They screened every patient in our ICU every day, and we diagnosed sepsis clinically. And we also used the methodology, the core methodology that was used and in that paper. We used exactly the same methodology in the same patients. And what we found was that if you do a clinical diagnosis using a prospective cohort methodology, you get 50% more cases. And it's not only because the core methodology only looks at the first day. You get 50% more cases. And the in-hospital mortality in our patients using the core methodology was exactly the same as in the core paper, 17%, 18%. But the mortality for people you diagnose clinically was 27%. So we have not cracked this nut, certainly not in my hospital, and given that the core methodology produced exactly the same results in my hospital, I think this is quite a reliable piece of research. So based on that, we would have about 18,000 ICU-treated cases of sepsis each year and close to 5,000 deaths in Australia. And as I said, we focus on mortality, and Ronaldo said it's the only thing you can get out of an electronic medical record, and it's a relatively easy thing to diagnose. We mostly get that diagnosis right. Not always, but mostly. But there is an evolving bigger problem, and that is the burden of disease in survivors of sepsis. So these are the extremes. These are three people, because this is actually the lady who's in the video, and it's on her website, so it's freely available. This was her trying to recover from sepsis. The muscle wasting is unbelievable, and it took her 2 years to get back on her artificial legs, and that's an extraordinary achievement. This is Matt from Queensland, who is an advocate for sepsis, he had several visits to hospitals and was sent away because he had man flu, and he lost all 4 limbs. And another young lady in New South Wales who I've been to give talks to try and raise money for her, because she has a young family and also lost 4 limbs from sepsis. And that's just the physical component of it. So just getting on to the subject of my talk now, which is actually supposed to be a bit about treating sepsis, okay, and being a leader of what is a team sport, because you don't do it on your own. And the reason I suggested that title was because I was thinking, this is not a whole of hospital problem. This is a whole of healthcare system problem. It's pre-hospital, it's in hospital, and it's post-hospital. And that's something that I and others are trying to work on in Australia. So your first role as a leader is to prevent sepsis. There is no doubt, and we've made considerable gains. We heard from Rob Herkes this morning about reducing central line associated infections, etc., etc. You know, when you don't do the right thing in terms of dressing up to put lines in and so on, you're exposing the patients to a risk of infection and sepsis. So the first thing you do as a team leader is you set an example, and you don't tolerate people in your environment doing the wrong thing. Not, you know, when I see people putting in arterial lines by having rolled up their sleeves and put on a pair of gloves, that used to be quite a common occurrence. It doesn't happen so much nowadays. And then actually treating sepsis. So Ronaldo talked about this, these men who got together to do definitions, at least for this particular effort. They're a slightly more diverse group of people who got together to write international guidelines for the management of sepsis and septic shock. This was published in Intensive Care Medicine and Critical Care Medicine. There are 93 statements on the early management of sepsis, 32 strong statements, 39 weak statements, 8 best practice statements. I'll explain what they are. And for 4, they had no statement. And this is a huge undertaking. You know, this was 2 years of work. I was part of it early on, but they wanted me to do multiple literature searches on things to do with mechanical ventilation, and I eventually withdrew from the process because I just couldn't do it to the standard it needed to be done. And I could read it all out to you, but that's pointless. You know, you can go and read it for yourself. It's actually quite a good document. It's a very long document. I quite like this, the strong recommendation. What do these actually mean? So a strong recommendation is something that most individuals in this situation would want this themselves. And a weak recommendation, the majority would want it, but many would not, and so on. And for clinicians, you know, pretty well everybody would use this treatment, and that patients should receive this treatment. And it could be used as a quality criterion or a performance indicator, and less so. And for policymakers, you could adapt this and use it as a performance indicator. This happens much more in the US, where they're likely to take something like this and make it a performance indicator and defund you if you don't do it. So what did they say? I've just picked out a few bits and pieces that I think are relevant to the deteriorating patient environment, if you like. So what's the first thing you should do when you come across someone who you think has sepsis or septic shock? So it's a medical emergency, and you should start treating it immediately. That's probably good. And they recommend that you should give 30 mils per kilo of IV crystalloid fluid within the first 3 hours. That's a strong recommendation, but with low quality of evidence. And that after initial resuscitation, you should come back and reassess them, which I don't think we'd argue with. Now, this is a best practice statement for which they say the statement should be clear and actionable. The message should be necessary. There should be a net benefit or harm that is unequivocal. The evidence should be difficult to collect and summarize. So, for instance, antibiotics. You know, we're never going to do randomized controlled trials of antibiotics in sepsis. And then for antibiotics, they recommend the administration as soon as possible and within 1 hour. And I think, you know, Harvey's colleagues at the CEC through their Sepsis Kills program have shown that you can change behavior, you can improve people's administration of antibiotics, etc. This, however, is a very interesting paper that came out just in the last month or so from Chris Seymour, who was intimately involved in the definitions concept. And this is a really interesting paper because in New York in 2003, because of the death of a a teenage boy who presented to an emergency department, was sent home, presumably with boy flu, and then died of sepsis. And his parents, that was Rory Staunton, and his parents are very strong advocates trying to stop that ever happening again, because those of us who are parents can imagine how you feel about that sort of experience in your life. And they've introduced what's called Rorys Regulation in New York, which means that hospitals have to have in place a protocol for the early identification and treatment of sepsis, and they have to actively screen for it in their emergency departments. Now, the protocol is not standardized across the state. It can be specific to your hospital, but it has to be approved by the New York Department of Health. And it has to include a 3-hour bundle and a 6-hour bundle. And the 3-hour bundle has basically its 3 things: take a blood culture, measure the lactate, and administer antibiotics. You have to do that within 3 hours. And then within 6 hours, you're supposed to give 30 mils per kilo of fluid. And what this study did, in a very complicated but very well done fashion, was it looked at the crude mortality and risk-adjusted mortality, in-hospital mortality, for completion of the 3-hour bundle and for the administration of antibiotics. And you can see that as the time to completion of the 3-hour bundle increased, your risk of dying increased. So quite strong data, and also for antibiotics. And this backs up Anand Kumar's data that suggested that for every hour you delayed antibiotics, the relative risk of dying increased by 8%. It's a bit less in this study, it's about 4%. But good data. So you should do those things. And similar findings for taking blood cultures and measuring lactate. Now, obviously, measuring lactate of itself doesn't improve anyone's outcome, but it may be an indicator of people taking the problem seriously and acting on it. Also of great interest in this paper is that the time to complete the fluid, the first bolus of fluid, had absolutely no association with outcome whatsoever. Now, I'm not sure we take away the message that giving fluid is not important, although it may not be. Certainly drowning people is not a good idea. And I think in Australia, certainly, we're much earlier users of vasopressors than they were in the US, although they've moved on. So quite clearly, we should, those things associated with antibiotic administration are very, very important, very strongly associated with recovery. Now, one of the things that you get to do as a specialist is stand back from a bit from the coalface and actually think. Now, I sometimes think my registrars and residents are so busy doing that they don't think. I know I didn't think a lot. You're so busy trying to do the things that you think someone else is going to get cross with you if you haven't done it. And that one of the things that when people ring you up, it's a bit like people ring you up and say someone's got pulmonary edema or had pulmonary edema, so I treated it. And you say, well, what caused it? Oh, I didn't actually think about that. The same is very true of sepsis. I mean, this is about source control. Clearly, if someone has got an abdomen full of pus, we generally want that drained. But there are other sources of sepsis that are not quite so apparent. You can guess, someone guess what that is? Yeah. So this is a lady who was referred to me in the ICU as having Guillain-Barré, and that was her CSF, which was full of pneumococcus. So the treatment for that is not plasmapheresis, it's antibiotics and other treatments for sepsis. So source control is very important. Sepsis is a syndrome, as Ronaldo said. You must think, where's this coming from? Because it influences your treatment and it clearly, profoundly influences your choice of antibiotic. Vasoactive medications, I mean, we've been using noradrenaline, and the first study the CTG did was on dopamine, which Ronaldo led, and through a masterpiece of placement, got published in The Lancet. It was a terrible study. I think we all agree now. It was a dreadful study. It was in The Lancet, so all good. and we don't think dopamine is very good for you. So noradrenaline, used very early. Vasopressin is still recommended, and a lot of my colleagues love it, and I must admit that I do use it, although the data for it is not that strong. And of course, the latest interest, and all these papers seem to have Ronaldo's name on them. I wonder how that comes about. So the latest thing, of course, is whether we should be using angiotensin II. We were part of this study at Royal North Shore Hospital. We couldn't recruit anyone because we couldn't find anyone sick enough. They weren't sick enough for long enough. Maybe that's because I live on the upper North Shore of Sydney, which is a sort of middle-class ghetto, more of an upper middle-class ghetto, really. So maybe our patients are all too well. But angiotensin II elevates your blood pressure and doesn't seem to do a lot of harm. That is my interpretation of that paper. Other things that you might think about in the context of I've gone to the ward to see a deteriorating patient. They're very sick. I'm interested in the cardiac output finger thing. I might have to go and have a look at that, because one of the things that it's really hard to get years of experience quickly. It's a bit like trying to develop old friends quickly. And to me, unresuscitated septic shock looks exactly like hypovolemic shock. But when you measure the cardiac output, we used to put pulmonary artery catheters in absolutely everybody. We don't do it nowadays. But when we used to put pulmonary artery catheters into people who had undifferentiated shock that turned out to be sepsis, and it looked like hypovolemic shock, and their cardiac index was always much higher than I thought it would be. So I'm quite interested in that. But I don't think we'll find out from adrenal, the study, the 3,800 patient study that Bala Venkatesh has led, and we should have the results by the end of the year, where the hydrocortisone reduces mortality in persistent septic shock. But certainly in the short effects, in the deteriorating patient scenario, I think there are other more important things. IV immunoglobulins are not recommended. Blood purification currently is not recommended. The Scandinavian group did a study on hemoglobin concentration, when you should transfuse patients. So if people are always saying, oh, well, why don't you give some blood? The hemoglobin's only 85. Well, it doesn't improve the patient's outcome. So that's a good reason not to give it. And mechanical ventilation, I think, again, we know we're not very good at doing what we think we do. We've done this repeatedly in the trials group. We've asked people, how do you manage this problem? Then we've actually gone and looked at how they manage it, and the two things are completely different. And you look at your 120 kilogram patient lying in the bed, which is about the average size of a patient in the ICU, it seems. Their actual ideal body weight is maybe 65 kilos. So your 600 mils is actually 10 plus mils per kilo. So if we want to do this properly, and I think there's a lot of good evidence for limiting tidal volume ventilation. Now, whether it matters in the first few hours or whether that's only when it's applied a lot longer, but I think it's a good idea to start as early as possible. I do tend to write up and try and use ARDSNet type ventilation in patients with sepsis and lung injury. Often we're ventilating people with sepsis not because they've got lung injury, but because they're cognitively impaired, or they're combative, or they're hemodynamically incredibly unstable and cognitively impaired and combative with a decreased GCS, and we just want to, it makes the situation more manageable. Nevertheless, I think it's best to try and limit the tidal volume. And as I've alluded to, we have this big problem. The physical side of the sequelae of sepsis can be bloody obvious. If someone's lost 4 limbs, you don't need to be told that their life has changed. What's less obvious, but a real problem, the data is starting to tell us, is the long-term cognitive impairment that can follow sepsis, with a high rate of functional and cognitive impairment. And in people in Jack Iwashina's study that he published in JAMA from the US, people who came into hospital with really normal cognition with sepsis because they'd assessed them beforehand, a significant number of those people who survive sepsis will have cognitive impairment equivalent to moderate dementia. And some work done in Cambridge by David Menon and his group shows you can actually get structural brain change in the tracts, in your neuronal tracts in sepsis. So this is a significant problem that we don't know what to do about it. And these are examples. I've tried drawing this because some of you know I did have an insulinoma and did wander around with a blood sugar of about 1 for about 6 months before I diagnosed myself. And I was sent, because they thought I was having epilepsy, I got sent to a psychologist, and I tried to draw that. I think it was a bit like this one in the middle here. So this is a near normal rendition by an unimpaired 69-year-old, which wasn't me. It's a very hard thing to draw. You should try. Moderately, severely impaired after pneumonia, someone who's had ARDS. And we've done some research at the George Institute, one of a young lady who's doing a PhD with me, and in fact this is this sort of impairment, quality of life impairment, is related to your severity of illness in the ICU. It doesn't matter whether it's ARDS or sepsis or whatever it is, you can end up, that's your rendition of that. So I sort of don't know whether I did what Darryl wanted me to do, but if you want a comprehensive review of guidelines for managing sepsis, then I don't think you can go past the Surviving Sepsis Campaign guidelines at the moment. There are some arguments about, there'll always be bits we'll argue about. They do say, you know, you can look at your individual patient, you can look at your environment. If you're in a lower middle income country, maybe this doesn't all apply to you, but that's right. What this is, the West Midlands Ambulance Service in the UK, and on every one of their ambulance now, as a consequence of Ron Daniels from the UK Sepsis Trust, they have a sign saying you can save lives from sepsis by acting quickly. And I guess that's probably my bottom line message here. We have these guidelines. I think they're a reasonable set of guidelines, but the key thing and the only thing that has really been demonstrated to change outcome for patients with sepsis in terms of mortality, and logically I hope that would change outcome in terms of the cognitive, etc., impairments afterwards, which are related to severity of injury, is rapid treatment. So get onto it quickly. Thank you.